So, thank you very much for inviting me to be the opponent of your defence. It's a great honour to be here, and I'm glad that we've got to be here in person after coronavirus. Okay, so in between the computer, two computers, there's some white paper. Just pick those up. So that's some tissue that I've provided you with. So you can either, for sweat, for tears, and if we need an emergency break, then just can be used for everything.
Perfect.
So I was asked to give a little bit of introduction about myself before we start, just for people who don't know me. I don't know if that's going to work. Is that working? It was working before.
This is the thing, it's clicking there but not there. Maybe we've not put the presentation mode on, that's why.
That may be the reason.
That may be the reason. So try it now.
Yeah, okay. So you're clearly the most important person in the room today, but I am English, so it requires me to talk about myself for a bit. So I'm a consultant orthopaedic surgeon. I work at the Royal Orthopaedic Hospital in Birmingham. It's one of the largest sarcoma units in the world. I didn't do a PhD, so you're already one better than me. I did do an MSc in orthopaedic engineering, and then I did a DSc, which is the highest research degree in the UK, which is a lifetime's thesis. We publish about 30 papers a year, 20 to 30 papers, so we've published about a paper a month since I've been a consultant. And we've published 29 papers on coronary sarcoma, so you didn't reference every one of them, so that's okay. I've had some informative posts as well with the chairman of the National Cancer Research for the UK, and I sometimes enjoy doing endurance events, though often not while I'm doing them. So for those people who don't know Birmingham, it's the second city in the UK. We also have a very old hospital, founded in 1909. It was originally called the Birmingham Cripples Hospital. That's not very PC, you can't call it that anymore. And you'll see from this lovely video, that's what the road looks like now. And it was originally owned by the chocolate factory. It used to be out in the countryside, so it was a TB hospital. And this was the original block of the stables for the Cadbury's factory. And now it's where the managers live. So it used to be full of horses, now it's full of donkeys. It's the largest orthopaedic hospital in Europe, just doing elective orthopaedics. And we look after about 22 million people for sarcomas and about 5 million for revisions. So we don't count Scotland to the Glaswegian in the audience, or Northern Irish. So we're about 55 million. So we look after about 40% of the UK. So just to give you an idea, we get about 4,000 referrals a year. We diagnose 600 primary bone tumours, 600 bone tumours, 190 primary bone tumours. And we've got data on over about 5,000 bone sarcomas and 5,000 referrals. So in our database, we've got about 1,200 coronary sarcomas and about 300 pelvic coronary sarcomas. And that's where we get our patients from. So it gets us into some unusual situations. Okay, so what's the plan today? I'm going to ask you some general questions about your thesis and about coronary sarcoma. And then we're going to discuss paper 1, then we'll have a break, and Mikhail will ask you about paper 2, and then we'll come back to paper 3 afterwards. Yeah. Okay, so first question I wanted to ask you was, what have you learned from your thesis? Not what academically you've learned, what have you learned about the process? What have you learned in the 8 years you spent doing this tremendous work?
It has many facets, of course. One of the sort of typical things, a cliche that becomes true, is obviously you gain a lot of respect for what you don't understand and how much you don't know. When you spend this much time on chondrosarcoma, you realize how much you don't know about osteosarcoma and Ewing sarcoma and all the other types of sarcoma, and how much effort it really is to be up to date on just one of these many entities that we can do. It has definitely been a process. I can see that I'm doing better work in Article 3 than in Article 1. I have learned to trust my instincts. I think my original thoughts about this have been very central to what I've been able to produce. Where I've given way to practicality or not done the work as thoroughly as I would have liked has come back and bit me in the backside. So ask the question first, know your variables, know whether they're reliable, have a good thought process about what they're going to show you and whether they can be used. And lastly, I've learned how exhilarating it is to create new knowledge. I'd never thought about the fact that I've spent my whole life learning knowledge created by other people. So when I got some of these curves out, I was just a nightmare to be around because it takes time to get it out to the world. And you think, well, what if I die and this knowledge is here and nobody knows about it? And it sounds silly, but I was just, it's really like heroin, I imagine.
Yeah.
Hmm.
Well, that's how you start, unfortunately.
Yeah.
And I presume you meant to say the love of your family and
Yes.
your colleagues' support and all the other things. He did mean to say that. That's what he meant to say.
Yeah.
But what about the practicalities of things? So you've worked in a cancer registry that you presumably didn't know much about. You said in your thesis before that you weren't particularly inspired by academia at the beginning. How's that all been for you? How did that go?
Working at the registry has been an eye-opener. We've the whole time known that we've got this huge facility just across the road, and the whole concept of this Oslo Cancer Cluster, which it's called, is that when we're nearby, it's going to create cooperation. It is obviously a tremendous resource, and it is right there, and it's full of numbers and data, and it's got these laws which enable us to get national numbers and questions for all types of sarcoma queries. So it's a tremendous resource. And so it's all about fighting for the time and rights and finances to be able to use it. And they're clever, resourceful people that are there to help us find our way. So that has been very inspiring. The world of academia is a bit mixed. I'm a pretty independent character. I'm one that has a little problem with authority at times. And of course, in academia, like many things, it's all about there's a tradition and a hierarchy, and finding your place in that, maybe particularly at my stage when you're a consultant, you're doing all these things all on your own, and in a way having to step back down to the bottom of the ladder is a little hard work, but we've got through that, and obviously the end result makes it all worthwhile.
Brilliant. So Einstein said, if you always did what you always do, you'll always get what you always got. So you've spent 8 years of your life writing an amazing book. My DSc thesis is that big, and it's only used for putting my laptop on to do Zooms because it's the right height.
Yeah.
How are you going to make sure that the important work that you've done in this 8 years makes a difference, and what difference do you think it will make?
Well, I fought to get published enough little books to start with for the department. The question, I think there is a literature saying that for a new finding to come out into routine clinical use from the hip fracture scenario, it takes about 20 years. And that is just ridiculous, of course, but that says something about the time that it takes. First of all, obviously, this is out there, but you've got to show it to people. You've got to get the voice out. You've got to spread the news. This has been a little difficult in the pandemic type of life we've been living. So my first plan is to present this at iSolves next year. That is one way of getting it out there. I send this to any international partner that we've had collaboration with in any way. I pester them. I contact people doing chondrosarcoma research to appraise their research and ask them questions. Sometimes I get answers, sometimes I don't. So you've got to create a network, you've got to talk about their findings, talk about your findings, and you've got to do the work to get this out and get people noticing it. And at some point, you've got to accept, I guess, also whether it gets noticed or not. There's a lot of noise, but you've also got to make noise about your findings.
So how do you convince a grey old professor, slightly rounding, that your research is meaningful and is to be believed? Because we all know there's some research out there that is maybe neither of those.
Well, I think we've just got to take opportunity to discuss it at every instance. I think what this boils down to is, in a way, that we've been using what's called GRADE for chondrosarcoma management for 50 years. And we've been doing the same research on the same topic for 50 years, and we've not really got any further. And that in itself is sort of reason to say, well, do we need to look at this differently? So I think, and we need to sort of think, what is it? We need to go back to the history like we did for Ewing and look at GRADE and say, what is the intention of GRADE? What was it they did 50 years ago, and what were they trying to do? And is that logical, and or what flaws does it have? And we need to look then at these numbers and say, well, okay, it's not that GRADE isn't saying us something, but how is it we're actually able to use it, and how is it are we able to use it to further understand chondrosarcoma? With these numbers, you're getting a small group where all the events are coming together in a small group, and that leaves us to be able to study those events much more specifically than if we do in GRADE, for example, where the events are happening in all the groups. So I think, in a way, it's hard to stand up and talk with big words about your own findings, but I think in a way you have to do this. I think this enables us to say, well, okay, we've got all the events in one group. What is it that's happening in this group compared to the other group, and what's happening within this group? So we need to re-examine a lot of good work we've already been doing, but we've been relating it to GRADE with confusing findings. We need to redo that with this work and see whether we can understand even more and get that high-risk group as small as possible, hopefully.
Good. So one of the other ways to do it is to think about validating your results. So you're very proud of your Oslo grading system, and it sounds very interesting. Statistically, it's close, but not quite there. So one of the ways maybe to think about collaborating with Birmingham and various other places. And perhaps we can help to validate your data.
That is the first step, of course.
So you have talked about a lot, or you have a lot of references, which I know Michael's going to explore a little bit later, in the literature. How easy is it to compare what we produce in Birmingham to what you've produced in Oslo, or what the Americans produce, or what the Australians produce, when you try to compare the literature?
It's very difficult. Basically, the literature is full of lots of different constellations, lots of cocktails, and the ingredients in all the cocktails is all different. So for some groups, they have lots of central chondrosarcoma, but they have also some dedifferentiated chondrosarcoma. Others include or exclude the other groups. So that, to start with, is probably the most difficult thing, is that chondrosarcoma isn't one disease, it's lots of diseases, and when they studied in all different mixes and matches, you're going to get conflicting results. Beyond that, there's also all sorts of types of different referral bias, in that we obviously have now national data, so that means that we're not getting the difficult cases, we're getting every case. But if you go to a system where you're a highly specialized referral institution, then you might be getting the more difficult cases as opposed to the less aggressive things still being treated elsewhere. And again, obviously in the States, there's all sorts of things about insurance and all sorts of things like that, which dictates also which numbers are you're looking at.
And what about the language of research? Do we all speak the same language? Clearly, I don't speak Norwegian.
I think a lot of the language is similar, but we don't spend enough time defining what we mean by it. We think we're talking the same language, but we don't always do it. And essentially, that is part of this same cocktail. We all talk about chondrosarcoma, but in essence, we're talking about different things, and we're not defining them. So a lot of these guidelines coming out now are making us define things in a different way than we were before, luckily.
So we need to split the apples and oranges rather than trying to put them together, which is what you've done very nicely in your thesis and to be commended for. So let's talk a little bit about registry data. This is a paper that you probably don't know, and I wouldn't expect you to know, but it came out this year, which is in the British Journal of Cancer. And it's talking about trying to compare registry data between countries.
Okay.
So we know that your registry in Norway is very good, but you did allude to, say, the SEER database in America in your thesis.
Yeah.
We have a national cancer registry in the UK, and this was a study trying to compare missing data and how that influences cancer registry data. What's your thoughts on registry data per se?
I think registry data are very variable, and registry data are, in a way, designed for big numbers, and if you're then missing a few variables, you've got such big numbers that you can overcome that. But when you're doing this with rare diseases, your numbers are still going to be small, and when the relative amount of missing numbers for the SEERS database is like 40% for a lot of variables, exactly in particular for the key variables, you've got to be very skeptical about what are these numbers representing, and what are they? What can you really learn from them? Where are they? So I think data quality is very key. That is what is so special about this, is that we're allowed to get in all the information for any case that is registered there to make sure that every entrance and every variable is being checked and double checked and is in place.
How does the Norwegian Cancer Registry, how does it get its data?
It has multiple catchment modes, so it gets data from automated registration, from radiation treatment, from surgery, from pathology, from death registration. So it has overlapping ways of gaining data that now are automated. So if you miss one from one place, you're more likely to get it from another place.
In your thesis, you talked about how you try to reduce the bias of that. So what did you do in your research to try and reduce the bias of registry data?
Well, I quality controlled them all. Basically, I used, in essence, you can say that I used the registry to find patients, and then I quality controlled all the data myself. Yeah.
So in your thesis, you also put down the required data sets that should be submitted when you put someone onto a database. Is that a lot of information, not enough information? Is there things there that you would have helped you do your research if it had been in that data set?
Well, the registration forms are obviously, again, dictated by the diseases with the big numbers, and typically by a staging system called the TNM staging system, which is the sort of worldwide accepted staging system for the common cancers. And it's all about size, and it's about lymph node metastasis and distant metastasis. So it's pretty coarse. And this is a system which doesn't really apply very well to really any sarcomas, and in particular chondrosarcoma. So the information in the form for chondrosarcoma is still definitely a bit limited, which again highlights the importance of assessing it. But interestingly, it has a blank space. So if we choose to be diligent about this, we can actually put lots of information in there. So it's full of possibilities that we've probably not been using to its maximum potential.
Okay, so you talked about the SEER database in your study. So give us a little, or tell the audience a little bit more about what the SEER database is.
The SEER database is a combination of lots of cancer registries in the States. and it is said to represent about 30% of the American population. It has, and they've sort of shown that with regards to age and pretty much within range, it's supposed to represent the general population of the States. And they are obviously, being a big country, they get big numbers, but their variables are pretty coarse. So chondrosarcoma is pretty much depicted as one disease, and even though they've changed that after a while, for example, this much more aggressive disease, dedifferentiated chondrosarcoma, was only a different entity in their register from 2005 or something. They also don't very specifically divide between chondrosarcoma of bone and probably what is there's a rare thing called an extraskeletal myxoid chondrosarcoma, which is a chondrosarcoma in the soft tissues, which now isn't even recognized as a chondrosarcoma anymore. So, and in addition to the really central things like grade, people have tried to look through and see that about 40% of cases are missing these key variables.
Good. So this is a slightly humorous look at orthopedic research. So obviously we have ours at the top. Our database holds all the answers.
Yeah.
And you have down the bottom, this registry tells us everything. So what are the advantages and disadvantages of registry research versus local database held research?
What are the advantages?
So what are the advantages and disadvantages? So what makes your paper better than my paper?
Well, again, it gives, in this case, national data, so it avoids reference bias from different cases being referenced and appearing at different centers. The disadvantage of it, if anything, is maybe that the variables are probably harder to change, possibly. If you have a local database, you have less politics and you're possibly more able to create new variables as they come up. I think that is a challenge to registries in general, is that it allows you to use variables that are already defined, but it doesn't so easily allow you to assess, have new thoughts about new data and new variables, although we've been able to do this.
So my data is my data, so I know my data. I know what's good about it, I know what's bad about it, but there's only one way of doing it.
Yeah.
And so I might not be doing it the right way, or Rob might not have been doing it the right way, whereas the advantage of registry data is that lots of people are doing it in lots of different ways, so you might be able to see something more interesting, but you don't know their data.
No.
You don't know how good their data is, what they've put in, how accurate it is. So those are just the two sort of differences for me. Go on, Carol. Did you want to say something else?
No, the register is obliged to present data on data quality. So they have legislature, again, that says that we have to show that we've got so many percent and these don't have missing variables and all this sort of stuff. So, but it takes time still to look at what's beyond the formal definitions and where the loopholes and where the weaknesses, definitely.
Yeah. So I'll come back to that in a bit, because I think you've overcome those problems. So we just want to start talking about incidents then. So you showed the table at the top, which you've showed before, and you reference the graph at the bottom, which is from the Dutch data. And what you can see on the bottom graph is a pretty steady grade 2 and grade 3, but a massive rise in grade 1 in Holland. And in your data, you showed a pretty stable grade 1, but a bigger difference in grade 2. So why do you think there's a difference?
I think there's lots of points to this. I think we have been very, the biggest uncertainty in defining these lesions is in between defining grade 1 and benign disease, so what's cancer and what's not cancer. And as the more aggressive it goes, you're better you are at defining this. We've been extremely conscious about trying to resist the temptation in our uncertainty to not define things as cancer. So we've been very conscious of this. I think if you look at the Dutch numbers, you look at the cases they're presenting, I think this curve is very problematic. There is a chance, of course, that for some freak of nature reason, grade 1 chondrosarcoma has blossomed in the Netherlands. But I think this is about definitions. I think this is about over-treating what we would call enchondromas. And I think that it has driven changes in WHO terminology, which is quite problematic because it's not internationally, at least, being addressed properly. So we need to help each other out with that.
Yeah, so this is the reason I left Brexit.
Yeah.
I didn't want to catch grade 1 chondrosarcomas off the Dutch.
Yeah.
But also, we could take it back to a geopolitical thing, is that the Dutch invented atypical cartilage tumours.
Yeah.
And the senior author of the WHO guidelines was Dutch.
Exactly.
So do you not think that, unfortunately, this is part of the problem when you have an idea and then you put it into things? Because when we looked at our data, which has, again, just been published recently, we've seen a massive growth in ACTs because now it's almost impossible not to call it an ACT, even though we know it's an enchondroma. And the trouble is, now in certain countries that gets paid for as a cancer treatment.
Exactly, yeah.
And so now people are curetting out benign enchondromas that perhaps didn't need treating.
Can I ask you, is this tissue-based or is it also
radiology? Just pure
defined?
radiology.
Yeah. That's another problem because the WH book essentially defines, they've renamed the grade 1 chondrosarcoma as what they're saying it doesn't spread, it's not dangerous, so we're going to give it a bit different name. But they did this after they've already had this huge big surge, and they call it an ACT, an atypical cartilage tumor.
And so why these ones in the red line, where you can see a rapid growth in chondrosarcoma, is that we had to biopsy stuff that we wouldn't have biopsied before. And now because it's over a certain size and it's over 5 centimetres, it's now called a chondrosarcoma rather than an enchondroma.
So the key is to not biopsy them.
Come on to that.
Yeah.
Don't get ahead of yourself. No, come on. So, let's talk about ACTs again. This is another graph that appeared in your thesis.
Yes, that's right. I had to create this myself because this was the only author that wanted money for reuse of their diagram. $50 American they wanted, so, yeah.
So, ACTs has been set at 5 centimetres. In your thesis, you came up with a size that you thought was more appropriate?
I don't think size matters.
Well, that's because you're a male. So, you talked about 8 centimetres. But from a statistical point of view, looking at that graph, and if I was going to come and tell you that everything over 5 centimetres is cancer and everything below 5 centimetres isn't, what does that graph show you? Educate the audience about the statistics of that graph.
So this is a graph where they looked at chondrosarcomas and they correlated them with histology, looking at which ones are enchondromas, the benign entity, and which ones are the grade 1, the least aggressive form. And obviously that distinction also in histology is quite difficult and open to interpretation. They then said which one is which, and they put a number and looked at size, and they said the ones that are more than 5 centimeters are more likely on histology to end as chondrosarcoma than an enchondroma and vice versa. But this difference was between 70 and 90%. So in both groups, you've got chondrosarcoma, and in both groups, you've got enchondroma. And again, the answer between both is unsure.
Yeah, so you've got more chondrosarcomas in the over 5 centimetres, but you've got some which are less, and you've got some enchondromas. The thing, so the plots show you the distribution, but the narrow boxes show you where the majority are, but they overlap, yeah?
Yeah.
Do you think that's a safe way to treat chondrosarcomas?
No, no.
Okay, so what does this MRI show us?
This is a sagittal MRI of the knee joint with the tibia, and there is probably a isolated cartilaginous lesion of, say, 1 or 2 centimeters in the tibia. without contact with the cortex and no particular aggressive features that we can see off these limited scans.
Okay, so the first one is a presentation. Second one is 9 years later.
Okay, yeah.
Are they the same size?
No, it's grown a little bit.
Yeah. So is that cancer, or do we expect enchondromas to grow?
So any lesion, if it has, say, a lesion has a limited capacity of growth, it's always going to grow from something to something else. So say it's going to turn out to be 4.8 centimeters. We don't know this from before. It's still going to grow from nothing to later on. The concept of growth has been because the histology and the microscope exam is so difficult, the concept of growth is sort of being key to say that this is chondrosarcoma. It's cartilage tumor, it's growing. And these are the words of Miss Bouvet from the Netherlands, is that growth is central. So we have highlighted this probably more than we should, and we have been at least said that it's going to be difficult to not treat this. But then again, if you get a tissue that is unsure, again, we have been prone to interpret growth as correlating with chondrosarcoma, but we're changing our thinking about that.
You said in your thesis that a percentage of routine MRIs of the knee will show a cartilage growth. Do you remember what that was?
About 3%.
Absolutely. So 3 for every 100 MRI scans, and you put some graphs in about how many investigations you have in Norway. You have a lot of investigations, huh? But you're going to throw up a lot of these things. Okay, so what's this then? If that one's definitely an enchondroma, let's say this is 6 centimeters.
Well, this is 6 centimeters. It's lobular. It has a typical sort of cartilaginous shape. It doesn't have any clear expansion. It's not sort of pushing this is again the tibia bone, the leg bone. It's not pushing it out. I would assess the cortical bone primarily on CT, but based on this, it's not really looking like it's influencing the hard cortical bone in any which way. So again, I would call this an enchondroma.
Okay, but it's an ACT, isn't it?
Because it has contact with cortical bone, we would advise this for a little bit of follow-up for 1 year. Yeah.
Okay. What about this one then? So this is, say, 7 centimeters.
So again, and the typical scenario would here be that he has pain and he's
from his rotator cuff.
Yeah, he's going to blame this, but in fact he has tendons in his shoulder that are degenerative, as a lot of it happens, and that's the cause. So what we're seeing here is a little bit more influence on the cortical bone. So this is clearly a little bit more influence in the others, but again, it's localized. It's not all the way through, but this needs. You need to have a discussion here with the patient about the sort of gray zone that you're in here. Okay,
so what's the arrow pointing to in C?
I imagine it's pointing to the thinnest part of the cortex.
Okay, so if you biopsy that, what's the pathologist going to tell you it is?
We're going to get an answer. This is highly differentiated cartilage.
And the radiologist will say?
This is an enchondroma or an ACT.
And then what are you going to do then?
So I'm going to have the patient in, I'm going to have a talk with them, and I'm going to say that I don't think this is the cause of your pain, this is why, and I think we need to examine your pain and address that so that you're happy, and then we need to keep an eye on this with a follow-up.
Okay, so what's the goal of surgical treatment of, say, this condition or surveillance? So what are we trying to prevent? Because if you biopsy this, it'll come back as a grade 1 chondrosarcoma because nobody can make a decision about what it is.
Yeah.
So what's your role as a surgeon to advise the patient? What are you trying to do?
Twofold. First of all, I'm trying to help them. I'm trying to help them solve their problem, which is probably not this, but pain. So I want to take care of that and refer them to someone that can help them with their pain. And the other side of that, I need to make a safety net for our insecurities and the dilemma that we have to make sure that if we see any changes of this that become more aggressive, we need to catch that in a responsible way
So
and
you're
treat it.
trying to catch this when it's grade 1 before it gets to grade 2 or grade 3, because those are the ones that metastasize, yeah? Whereas you've shown elegantly in your study that purely grade 1s probably don't. So then there's a question about how we treat it, but your treatment goal is to stop the tumour metastasizing and killing the patient, isn't it? And it's about when you intervene, because we know this is a slow-growing tumour.
Timing, yeah.
Yeah, okay, and then this is clearly a chondrosarcoma.
Yeah.
So what would this be on your Oslo grading?
This is probably just within an Oslo low risk, I imagine. We would need to measure from about the end of the arrow and into the cortical bone. And well, it's an extremity based anyway, so it would for sure be Oslo low risk.
We'll come back to part 2. So what's this then?
This is your fantastic follow-up of cartilage lesions chart with is it the back tip or something?
Yep, back tip, yeah.
So this is a way of all these findings coming in. How do we differentiate which ones need follow-up, which ones don't, which ones need treatment, and how do we follow them up?
Okay, so we base it on various factors and try to base on the MRI where they should be referred to a specialist centre. It's not about treatment, it's about referral. But worryingly, these are the results from the back tip. So in the black, we have enchondromas, biopsy-proven grade 1s, grade 2s, grade 3s, and D. diffs. So if we go back tip 1s are less than 4 centimetres. That's what makes it a 1. And if we look at back tip 2s, A means that they are no scalloping. So 1A is less than 4, no scalloping. But you can see by the time we start to get scalloping, especially in C, 1Cs, under 4 centimetres, 2Cs, we've got a significant number of chondrosarcomas in there now. So do you think we could use something like this as a guide to treatment rather than just surveillance?
How do you mean use it differently than what it is now?
So we're going to come into biopsy a little bit later, but do
Yep.
we need to biopsy them if we know that basically any of the Cs, which is generalised scalloping, easily seen on imaging, have got a significant portion of chondrosarcomas in there? The only ones we would be missing would be the 2As and 2Bs, which are the over 5 centimetre ones.
I think that we need to, if we're going to solve that, we need to get again beyond grade. I think that essentially what we need to do is we're staging, and if something is in the medullary canal and it has limited levels of aggressiveness, then I wouldn't be concerned whether the histology is enchondroma grade 1 or grade 2. I think people are walking out on the streets with this disease inside, and I don't think there's a biological potential in the grade number per se. I think it's about staging, it's about when is it progressing, and that we need to look more strictly at the combined radiological features and not alone on
Have
grade.
you seen our paper on circulating DNA?
Yes, I have, yep.
So that may be an interesting way of
Absolutely.
either predicting local recurrence or working out which ones are problematic.
Yeah. So that basically shows that you can detect little bits of tumor in the circulation in a blood test, and basically you can see that on the more aggressive tumors you can find it, and on the less aggressive you can't. Yeah.
Trouble is, it doesn't work on everybody.
No.
So getting back to our beginning, and I asked you about bias, and why I think your papers are excellent is because you've not just taken the data at read, you've not just done a SEER database pull out and then just take it as read. You've gone to look at the x-rays, you've not reviewed all the histology, but you've reviewed some of the histology.
Yeah.
Tell us how many people didn't have their x-rays reviewed and how many didn't have their pathology reviewed in the series.
Okay, so we reviewed 223 of 311 of those included.
So nearly 100 you didn't, so a third you didn't review the x-rays.
So, and the problem with that is that old films, old-fashioned x-rays used to be on films and not on the machines. They used to be stored underneath the hospital, and they just take up too much space. So what they do is they say that, well, we've had them for 10 years, perhaps 15, we're getting new patients in, we need to clear up. So what we managed to do was to actually salvage a fair bit of the old films just before they were cleaning up. But it is a problem that these are removed.
Absolutely, it's not a criticism at all. It's
No.
a practicality and difficulty of doing
Absolutely,
research.
yeah.
And if you look at a lot of ours now, it's from 2007, and the only reason it is from 2007 is that's because when we became digital X-rays, and
Yeah.
they're all on a cloud somewhere.
Yeah.
Okay.
So for the pathology, we weren't just with radiology. I was very, very lucky that my good friend and colleague Ingeborg Takspal was able to spend the time to review all the radiology that was available. For pathology, the pathologist also did a magnificent job, but they just weren't able to put the time to do everything
Absolutely.
quite reasonably. So we'd had to pick someone.
That's right. Okay, well, their vitamin D levels are already very low anyway, so they can't spend any more time in the dark. So one of the interesting findings for your paper was the equal distribution between males and females.
Yeah.
And in the higher grade tumours, were there more males than females? Or metastatic disease, sorry, I should say from your graph.
Well, there is. We've seen that there is more males that in the local recurrence cohort, and there's more males in the high risk cohort. So I can't remember exactly looking only at grade, but if you combine it,
in your presentation, you showed that males was an independent risk factor and on multivariate for metastatic disease. But we've got equal numbers of males and females, but there wasn't a difference in terms of their distribution. So we published this paper recently with a multinational group that shows that women who are premenopausal have much better survival than males or post-menopausal females, which was interesting.
It was a great paper because originally there's also been an insinuation that the rise in chondrosarcoma is perhaps related to estrogen use in the population. And again, this is very contrary to that. This is saying estrogen is good.
Do you know anything about normal cartilage research that would suggest why there may be a link between cartilage and female hormones?
No.
No, that's
No,
okay.
no.
So you don't unless you look at it. That's the whole point.
Yeah.
Unless you look at something, you never bother looking at it. But there's estrogen receptors in normal cartilage.
All right.
And actually in the sports world, females have more cartilage problems, defects relative to males. So there may be something in it. Watch the press. Oh. Okay. So is this a safe margin?
For these people trying to maybe get to a better part of the world, it might be a safe margin. But obviously, it's a matter of perspective. It doesn't look very safe, and it wouldn't be for us.
Okay.
Yeah.
Is that a safe margin?
Yeah. It
So-
probably is, but it doesn't feel like a safe
So
margin.
when is a margin getting close dangerous, and when is a margin getting close acceptable, like in this case?
So basically, that is, we can produce numbers that your group has for distance, and we can say that this is associated with a certain percentage risk of local recurrence. And it is up to us to interpret that in a way that's reasonable for everyone. But again, people have different opinions depending on the consequences of this distance. So it is very valuable, but at an individual level, it's difficult to say what's appropriate for each person. And of course, at the end, the margin is what it is and not what you want it to be. Yeah.
But could you imagine a situation in the pelvis where you have the choice between limb salvage and or not, and one meant that you could get more than a 2 millimeter margin, and one said that you couldn't, you're going to be too close to it? Would that influence your decision in what operation to do?
I think that is the sort of crux of the situation, is exactly how secure are you that you're going to get this free or not, and how close is close. I think there's a very big difference between getting close and being confident that you're going to enter the tumor. I think those are two very different situations. But again, I think that we need to convey this to patients in the best possible way, and we need to include them in the decision making, saying what is safe or dangerous for me.
And should the role of margin, should the margin be the same for the same group of grade of tumour? I know you don't like grade, but do you think we should alter our margin for the grade of tumour?
Well, you have your group has a publication exactly saying that for higher grade, a more extensive distance of the margin is associated with safety. So the less aggressive it is, the closer that you can go. And that makes a lot of sense. This grade, we don't have this before surgery. So essentially, but we do radiologically see whether it is aggressive or not, and you can transfer the same thinking to that for sure.
So very quickly then, this is metastatic disease in chondrosarcoma. I know you're not a radiologist, but
yeah,
definitely cancer on the bottom. What about the top one?
It is, again, your colleague Davies has done a great paper looking at the size of small nodules. And he's found that in the setting of chondrosarcoma metastasis, nodules under 1 centimeter, in fact, 80% of them turn out to not be metastasis. And I think that colors us when we see these on X-rays or CTs and we have them in the clinic. I think probably we have a tendency to overemphasize this.
So all the other three aren't metastatic disease. They never became metastatic disease.
Yeah.
But they would have been labelled on a CT scan as possible metastases.
Yeah.
But unfortunately, that then goes onto your database as metastatic.
Yeah.
So it's got a huge consequence, not just for you, for our research, for everyone's research, about whether we call these indeterminate pulmonary nodules not cancer, or whether we call them cancer.
And on that same topic, registering data is a really difficult job. So you can put someone to register the data that appear in clinical notes and all this sort of thing, but to understand the difference between these and to get the registration of a variable of metastasis, which is the huge big events in your research, correctly, you really need to involve highly trained staff.
And you can see in the breakdown of the IPNs that if it was grade 1, it was highly unlikely to be a metastasis, versus if it was grade 3, it was more likely to be. So it's about taking all the information as well, isn't it?
Yeah.
So this didn't show, but John Charnley said that nothing spoils a good result like long-term follow-up. So should we follow up our patients for chondrosarcoma, and if so, for how long?
I think the interesting thing about the sarcoma world is very different to other cancer forms. In other big cancer forms, you have to show that you're able to detect a certain amount of events to be allowed to call people into the clinic, because calling people into the clinic is an intervention in their life, causes anxiety and all these sort of things. In sarcoma world, we've had this sort of token sort of get out of jail card and just say we can just follow everybody for 10 years because it's so rare, we don't know what happens. And I think we need to stop doing that. I think that we can see that it is not necessarily for most patients. Some patients have late events that we've looked at and need longer follow-up, either locally or systemically, but a large portion of events don't need more than 5 years of follow-up.
Do patients like being followed up?
People instinctively often say yes, but it is associated with a lot of anxiety. A lot of anxiety when you get that letter in the post, come to the oncology hospital to pay us a visit, and a lot of relief afterwards when everything is okay.
And how long does that relief last for?
Well, until the next letter arrives. Yeah.
Probably for about 10 minutes out the door.
Yeah. So it is a real burden for people coming to the clinic. Yeah.
Okay. So one of the last things I want to just talk about, and I realise I'm going on a little bit, but I won't take so long next time. You've got a chondrosarcoma here, which is predominantly grade 1, in most of its features, with a small area of grade 2. Do we classify that as a grade 1 chondrosarcoma, or do we classify it as a grade 2 chondrosarcoma, and why?
So even originally in Evans's original work, the guy who invented grading, he saw that even if there's only a little area that is more aggressive, then this is the area that defines the biology of the tumor, and it needs to be created this. And a colleague of Professor Jay's from Finland has looked again at the numbers and re-examined their material and said that if you actually look even closer, then you can find more aggressive areas in about 30% of specimens. So it's the most aggressive area that defines the tumor. In saying that, tumors can be quite big, and the pathologists, like the margin we talked about, have no chance of looking through this whole tumor. So they take 10, 12 sections and they look over that area, but there could be areas that they're not seeing, obviously.
How reliable is a biopsy at predicting grade of the tumor?
An open biopsy is better than a needle biopsy. People are doing less open biopsies as the operation. They're doing needle biopsies. You get less tissue. Even if you try to find areas on imaging that is more aggressive, you're not necessarily going to find it. So the publications on this are very different. But it's often, the question is often for people that want to use biopsies, say, well, how good am I at finding the answer that I want, more than putting in mechanisms in their research to say, is this working or is this not working? So my mentors here had a pretty early experience and instinct that said that this isn't reliable enough. And that has been, they were obviously working in an age where all this literature wasn't available, so they had some instinctive tokens about that, which and some of them were right and some of them were not right, of course. But on that aspect, I think they're spot on. You just can't rely on it.
So should we biopsy chondrosarcoma then? Yes or no?
No.
Okay, good.
Yep.
All right. I'll pass on then. Well done.
Thank you. Should we have... Yep.
Thank you. Lucky for you, Joachim, nobody wishes to comment ex auditorio, so now we're going to have a short break for 10 minutes, and then we come back for Mikael.
Just a few funny pictures, and otherwise I'll do a little bit differently. That's good.
You've got them up there already.
Yeah, it's on his here, so you can put it down if you want. Yeah, there is one. Yeah, great. Tomorrow. Yeah. And you?
Yeah, tomorrow.
Yeah. Otherwise,
Come all this way to
exactly.
enjoy
Yeah.
some glasses of wine.
Exactly. So we see.
Yeah,
The party. Yeah.
Kangaroos. So we're not being able to talk about clear cell chondrosarcoma, which I found.
Yeah.
Maybe okay.
Good.
Okay, so I'm
You looked
prepared.
up the
Yeah.
Cool. Doing great.
The plan is to just hang out here just 2 minutes and recoup, and then basically I imagine a lot of people need to go home, get changed, or to get kids and stuff.
We're more casual tonight, or still smart?
No, it's smart still. Yeah. So and basically we're staying down at the same hotel as you, so we're going to head down there,
All right, just
get
the
changed, have a beer, and then just walk up to the restaurant. Is 2 minutes just around the train station, so we can just meet up down there.
Yeah.
And
I'll give you my mobile number afterwards.
yeah, that's brilliant. I'm looking forward to that beer.
Yeah,
I don't know what the university would say about that, but
I will join you.
ja, kjempefint. I have my tissues ready. Ja, så bra. You managed to get tomorrow. You managed to get tomorrow off.
Yeah, I'm
Yeah.
operating. I was supposed to be operating tomorrow, but I moved it to Sunday because you don't want to come all this way and then not enjoy the fun part, do you?
No.
Yeah, I had the polite conversation last night, and then today we've been working. Tonight, hopefully, we can have a few beers and relax and
Brilliant.
celebrate.
Fantastic.
I shall go home with a slightly fuzzy head tomorrow.
Perfect. Perfect.
Når det blir så performance-aktig.
Det er kjempemorsomt, altså.
Bare ta litt vann også, ja. Har du også fått, eller? Du har også fått? Ja? Ta et glass. Ja, yes. Perfekt.
Jag har bara någon, jag kan
Ja,
klicka fram det
Ja.
på 2 bilder.
okay, yes.
Okay, then we're going to start again. The second opponent is Mikael Skorpil from Karolinska in Sweden. So maybe you can find some black holes in the research. Good luck.
Thank you. Mikael. Yep.
Yeah, that would be tough, difficult. Thank you for inviting me here. I'm very glad, especially as a radiologist. We know it's important, but you've also written it in the thesis. We like that. So I'm from Karolinska, and we do it a little bit differently.
Yeah.
And that's good. I like you. So I'm going to go into paper 2 a little bit on details and thesis and reference.
Yeah.
I'll do as Joachim, take off my...
Absolutely. We're starting to warm up here. Yeah. It's not a fight. No. It's a cuddle.
And to begin with, also, I work with Ingeborg Taxdal.
Yep.
And so it's very important who looks at the images.
Yeah.
And she's very, very, very good. They're all good here, but I mainly met her. But that's important to have valid quality data. I think that's the reason for these 3 good articles. Yes, and I had to do some research on the researcher.
Aha. So we try this one. Den virket ikke. Yeah. Try that. This one is on a mute now. How do we turn that off? Yeah.
So I was so impressed of your all Norwegians email, the good English. but I got an explanation that you actually lived in Australia.
Yeah.
And also in Ireland, I think. I'm not musical, but I think I can hear both accents.
Yes.
Yes. And you're also a keen marathon runner.
That's right. Yeah.
So and a family man as well.
Yeah.
So I think this is a
Very
good
important.
image.
Thank you.
And everyone isn't a doctor in here, so I know it's a party today, but why have I popcorns here?
This is because popcorn calcifications are typical of chondrosarcoma, I imagine.
Yeah, exactly. It's a good.
This is the descriptive radiology language that we were talking about beforehand. Yeah.
Good. Yes, okay. Yes, and also I must say I like the thesis, and I also like that you have a personal tone in it.
Okay.
That's always nice. And Lee has, of course, asked a lot of questions. But and I think, and also when I read it and try to come up with questions, it's hard because you answer them yourself in the thesis. So, but I'll ask them anyway.
Yeah.
But what do you think is best with your thesis? What you're most proud of?
I am in a way. With regards to process or results, do you think? With regards to results, I'm very. Well, I guess maybe actually the whole sort of that I've found something. I've had a notion and I've had an idea and I've had a thought about what is this telling us in a way based on descriptive radiology. I've had a think about the basis for this strange picture with the dilemma. I can tell you about that, where we have the two tumors with the one that's small and the other one is big. I watched this really cheesy episode of one of these American tumor medical series or something, and it was all about a brain tumor in a really difficult location. And they had days and days of preparation, and they filled the theater, and they asked her, "How are you going to get this out?" And she had to say, "Well, for these last weeks, I am living the tumor, I am the tumor, I am thinking the tumor, I'm this, and then I'm all that." And I was just like sitting at home going, oh, you know. And I was out running, and it's when you're out running, you have all your really good thoughts. And I thought, well, maybe that's not a bad idea to have a think like this. And I thought, well, we spend all this time at work looking at tumors, and particularly with cartilage tumors, and what we're really looking at the pictures is we're trying to say, what is it this tumor is indirectly telling us? What is it it's saying? Where is it going? What is its potential? And I've always sort of also had this nagging feeling that it's obviously this metastatic event that kills us. Not me, hopefully. And in that sense, I said, well, which tumor would I really like? What is the sort of difference between these? And that's sort of when this dilemma came up, and I had a sort of pretty clear saying that, well, this big soft tissue component, that must be really nasty. That is obviously showing much more sort of oomph, out here I go, come on. And so I'm really just happy that I've had a logical idea about something, and I've done the quality work, and then I'm sort of being able to actually find the result as well, which is fantastic. I'm very proud of it.
Yeah, it's really good taking an idea and verifying it, and it's a very interesting data. Yeah, and what was hardest with this thesis these years?
The hardest part was the time, getting the time, finding the time to do it, fitting it into a busy life, a busy work life, busy home life, and getting it. I think I could have easily got this data and produced 3 articles about grade, and I would have got that into places, but I've chosen on purpose to do things a little bit differently, and I'm not sure that the journals are that keen on it. I don't know whether that's a bit paranoid, but I think often they prefer to get things the way that they're used to getting things. And in addition to being a novice, I've had to sort of learn this whole game of that you play with reviewers and everything. So having to go 3-4 times to get a paper in, that's pretty demanding. But we got there, which is good.
And that's, I would say, also interesting because these new ideas often are published in not the highest impact journals. Because they won't take it in, they want what exists a little bit better.
Yeah.
So paper 2. So in the title, I must say, I always like the word novel. A novel system predicting. For me, that's really research, finding something that's new.
Yeah.
That we didn't know about.
Yeah.
Yeah, that's cool.